Hi, my name is Jiye Kim, and I'm a clinical data scientist at DeepHealth. The title of this talk is Machine Learning Model Identifies Malignancies Earlier in Screening Mammograms. Here are our disclosures. Screening mammography is the most effective method for detecting breast cancer early, and it's been shown to reduce breast cancer mortality. Despite its efficacy, the perceptual task is challenging, resulting in cancers being missed occasionally. And studies have shown that a significant proportion of these missed cancers are visible in retrospect. And here we apply custom-built deep learning algorithm to study if AI can help detect cancers earlier in clinically negative prior mammograms of cancer patients. I'll define some terms that I'll be using throughout the presentation. We define an index cancer exam as a screening exam performed up to 3 months prior to biopsy-confirmed malignant pathology. A pre-index exam is defined as a clinically negative screening exam interpreted with a BI-RADS 1 or 2 and acquired between 11 to 24 months prior to the index cancer exam from the same patient. Finally, a negative exam is a screening exam interpreted with a BI-RADS 1 or 2 confirmed with a subsequent negative screening exam acquired 12 to 24 months later. Our deep learning model was progressively trained in a series of stages. Stage 1 consisted of patch-level classification using cropped image patches from 2D mammograms. In Stage 2, the model trained in Stage 1 was used to initialize the feature backbone of a detection-based model. The detection model, which outputs bounding boxes with corresponding classification scores, was then trained end-to-end in a strongly supervised manner on full images. This model was trained on close to 100,000 exams, including over 7,000 cancer exams. Here are the two datasets that were used to evaluate a model. These datasets were retrospectively collected under IRB-approved protocols. Exams from Site A came from a community hospital in Oregon, and the exams are acquired with GE. Exams from Site B came from a single health system in Massachusetts, and the exams are acquired with Hologic. Exams from both sites were FFDM, and all of the pre-index exams came from the same woman as the index cancer exams. The model's standalone performance was additionally compared to 5 full-time breast imaging specialists who retrospectively read the exams collected from Site B in a reader study. Importantly, these evaluation datasets did not overlap with the data used to train the model. Here are the results for dataset A. The model achieved an AUC of 0.94 on the index cancer exam, as shown on the ROC curve plotted in blue. And our model achieved an AUC of 0.74 on the pre-index exam, as shown on the ROC curve plotted in yellow. We note that the pre-index cases are considered much more difficult, hence the reduced AUC on these. And these can be thought of as challenging false negatives, as these were all clinically interpreted as negative with BI-RADS 1 or 2 at the time of initial read. The average interval in days between the index and pre-index exams was 466 days. At the mean BCSC radiologist recall rate, which is roughly about 10% and denoted in the yellow dashed line, our model would have flagged 38% of these clinically negative exams for additional workup. So without compromising recall rate, our model identified a significant proportion of prior exams of cancer patients as malignant. And here are the results for dataset B. Dataset B was collected with Hologic, and again, dataset A was collected with GE. But despite this difference, the results were highly consistent. Our model achieved an AUC of 0.95 for the index cancer exam, as shown in the ROC plot on the left, shown in blue, and an AUC of 0.77 for the pre-index exam, as shown in yellow. On average, the interval days between the index and pre-index exams was 419. At the mean BCSC radiologist recall rate, again, roughly about 10%, our model would have flagged 46% of these clinically negative exams for additional workup. For dataset B, we compared our model's performance to 5 full-time breast imaging specialists. And here, each dot represents a radiologist's performance plotted against the model's RFC curves. Specifically, each reader's sensitivity and specificity points are plotted in blue for their performance in the index cancer exams and yellow for their performance in the pre-index exams. As you can see, the model outperformed all readers on both the index and pre-index exams, as shown by the circles being below the corresponding model's RFC curves. The average reader performance is shown as crosses for the index and pre-index exams, where the length of the cross indicates reader variance. For the pre-index exams, the model demonstrated 17.5% increase in sensitivity at the average reader specificity. And the model achieved a 16.2% increase in specificity at the average reader sensitivity. For more detailed results for the index cases, we have an abstract dedicated to this topic that I suggest you to check out. Okay, so next I'm going to show you a couple of examples. And here's an example from dataset A. On the right is an index cancer exam where our model correctly localized and identified the malignant lesion as shown in the red box. On the left is a pre-index exam acquired from the same patient about 13 months before the index cancer exam, and the model correctly identified the malignant lesion in this case as well. As you can see, the lesion is much more conspicuous in the index as opposed to the pre-index exam, but our model was able to consistently localize the malignancy in both the pre-index and index exam. Here's another example from site B. Again, the model correctly localized the malignant lesion in the index cancer exam, as well as in the pre-index exam. So for this patient, the pre-index exam was acquired a little over a year before the index exam. And for this particular case, none of the readers identified the malignant lesion in the pre-index case. So in conclusion, our deep learning model detected malignancies in a significant proportion of clinically negative pre-index exams of women with breast cancer in 2 independent datasets without compromising recall rates. Results were generalizable across exams acquired with different manufacturers. Our model outperformed 5 fellowship-trained breast imagers in a controlled setting. And together, this suggests that our deep learning AI has the potential to help radiologists detect breast cancer earlier, which could ultimately improve disease prognosis. Finally, I'd like to thank our funding sources and other contributors to this project. And please check out our other abstracts listed here. Thank you.